afternoon and good evening, everyone, and welcome to today's webinar, co-organized by the ITU WHO Focus Group on AI and Health and the Department of Biomedical Informatics at Harvard Medical School. My name is Matthias Greschel. I'm a physician and a researcher with a background in infectious diseases, and I'm supporting the Focus Group on AI for Health in several activities, which is co-hosted by ITU and the WHO. This all happens under the umbrella of AI for Good, which is the United Nations leading initiative around how AI can help to achieve the Sustainable Development Goals. If you're confused by all these abbreviations or want to know more, just check out all the links that we'll post in the chat or reach out to us. We're always looking for people to join the effort and help out. In these AI and Health webinar series, we try to cover relevant aspects of how AI can help deliver healthcare and all the challenges, the many challenges associated with it. And a couple of weeks ago, we've talked about bias. Just 2 weeks ago, we were introduced into a large systematic analysis around models used to diagnose COVID and how most of them were useless. And today, and in 2 weeks, we'll have 2 scholars from Latin America who will give their perspective on how they employ and deploy AI solutions. So I have the privilege to introduce Hugo Morales today, giving his talk around AI for health in developing countries. And I'm really happy he's here. Hugo, please turn on your cam. Hugo is an infectious disease physician who trained at the hospital, the Clínicas at the University of Sao Paulo. And I'm really excited to have Hugo here today because he's not only a frontline physician working on intensive care, but he's also a researcher and entrepreneur who packaged his AI models into a company and deploys them now in many hospitals. He founded Laura, which is a company, an AI health tech focused on designing and also implementing AI solutions. And Laura received numerous awards and is now being implemented in 40 different health institutions in more than 30 cities in southern Brazil. So really excited to hear more about it. To the audience, if you're on Twitter or YouTube, please consider joining the Zoom link because then you can ask questions. There's the Q&A functionality at the bottom. Please submit your short questions. The shorter, the better. And with no further ado, Hugo, nice to have you here. How's the pandemic situation in Sao Paulo?
Yeah, thank you, Matthias. Thank you very much for inviting me and the opportunity to share our experience here. Our pandemic actually currently it's going better in Brazil. I'm actually in Curitiba in the south part of Brazil, and we have a trend of falling the number of cases. That's a good thing. I'm gonna share my screen.
Yeah, go ahead.
And
the floor is all yours.
Thank you. Just please tell me if you're able to see my slide here.
It's showing up perfectly.
Okay, thank you very much. And please, if you have any questions, you can just interrupt. I think it's kind of hard to manage seeing the questions. If you want to interrupt and just ask, please feel free. Thank you very much. So, like I told, just thank you very much for the invitation. I'm really very honored to have this opportunity here and to share our learnings, our experience in this new world of deploying AI in healthcare. As Matthias kindly told, I'm an infectious disease physician by training, and I nurtured a very special interest on technology over the last years. This interest came from the perception that only through technology we can democratize quality of care and patient safety. This insight, the technology is the only way to democratize quality of care and patient safety, happened, an insight happening in 2016 when I first met Jackson Fressato. Jackson is a system analyst that had lost his daughter due to sepsis complications in a very early stage of her life, especially complications caused by a delay in sepsis recognition and diagnosis and treatment. So after this event, he put all his effort to build a prototype solution that could help healthcare professionals to early detect patients with risk of sepsis. Together with Christian Rocha, a computer scientist who holds a mastership in artificial intelligence, we founded a company in order to bring this dream to reality and named the project Laura as a tribute to the little girl. We've started our project in sepsis. However, we quickly understood that sepsis was just the tip of the iceberg. That specific process of care, that sepsis care, was one of the many demonstrations that the way we currently deliver care has systemic problems. We deliver care in a chaotic and complex way where concurrent processes happen at the same time. And now we are drowning in bureaucracy and big data, which makes this context very prone to error and potential patient harm. This is especially true in developing countries where there's a lack of routine processes, healthcare profession shortage, and a high turnover of healthcare professionals, both inside and outside hospitals. So we realized that we were facing not just a focus problem, we're facing a systemic problem. And therefore, we needed a systemic solution for that. Over the years, we've developed and implemented two main solutions. The first one's LoRa Clinical Intelligence. That's a 3-in-1 solution. It brings a decision support tool, a communication hub, and a protocol management for hospitalized patients, and also LoRa Care for the outpatient settings, which was developed primarily for COVID-19 and after extended to other acute and chronic disease to increase access and to improve care coordination. Therefore, currently, LoRa ensures the best care for patients and helps healthcare professionals to deliver better care throughout the complete journey of the patient. When the patient is at home, a machine learning algorithm is applied in order to enhance user experience by answering basic questions and doubts about health condition. If a symptom is detected by the algorithm, the patient is redirected to a triage web page and a symptom checker. Once symptoms are verified, patients are classified into 3 main subgroups: mild, moderate, and severe. Patients classified as mild disease are followed by a digital non-human clinical pathway in which every 2 or 3 days, the algorithm interacts with patients through messaging platform. And patients falling to moderate or severe disease are prompted to teletexting or teleconsultation with a healthcare provider. All patients stratified by their severity can be monitored by a healthcare provider in a platform, allowing the interface. In such a way, the process deployed through the algorithm ensured prioritization of individuals with more severe presentations, while continuous oversight by healthcare providers afforded. I'd like now to go in more details of the LoRa Clinical Intelligence. That's our platform for inpatients, for hospitalized patients. We know that an average of 10% of hospitalized patients will suffer for clinical deterioration, which is a process of clinical worsening that could lead to unplanned ICU transfer or death. We also know that patients who experience that clinical deterioration show evidence of physiological derangement 6 to 24 hours prior to their deterioration. Therefore, early detection and the right treatment is mandatory to achieve better outcomes. How is the current workflow in almost everywhere in the world? The nurse team routinely assesses the patient's vital sign in the wards every 6 or 8 hours and applies a score. For instance, modified early warning score or a national early warning score. If the score is above a cutoff, the nurse team will call the rapid response team or the emergencist to evaluate the patient. That one is called its afferent limp. The next step is the evaluation by the physician who make a diagnosis and initiate intervention and decides if the patient stays in the ward or has to be transferred to the ICU. The major problem here is that this system doesn't work in 25% of the times. That's it. 1 out of 4 clinical deteriorating patients doesn't receive the right diagnosis and treatment. And this is data from developed country. We know that this scenario is even worse in developing countries. Failure to recognize clinical deterioration is multidimensional. It's not easy task to tackle. The first, we'd like to highlight here 3 obstacles that we consider most important. The first one is disconnected data. Today, we have digitized data, even in the developing country, but they are separate in silos and far away from the team, far away from the decision maker. We spent, for instance, double time looking for data than actual taking care of the patient. The second one is the low performance of current scores, early warning score, national, modify. The gold standard were conceptualized back in the 90s as a score to be evaluated by the bedside of the patient. So it needed to be short and fast to fill. This has a negative side effect on discrimination performance. And the third one, the last but not the least, it's about communication error. We know that communication errors are the leading cause of adverse event in every hospital setting in the world. Once again, developed countries show an average worse performing on detecting and treating patients with clinical deterioration. That correlation was recently reinforced by papers showing that patients with COVID from developing countries have higher mortality at a younger age profile compared to developed countries. And how can we help this? What's Laura can bring to the surface? We created a platform that connects to the electronic health records, aggregates all the information, uses machine learning model to predict risk of clinical deterioration and other risks, and communicates in a smart way. Why machine learning? Because currently we have a system for clinical deterioration that use, like I just told, the scores with low performance with a limited number of variables with fixed thresholds. Simple to follow algorithms used like trig and tracker are also difficult to put in the workflow due to heavy workloads and challenges in getting medical officers to review within recommendation timeframes. That's the major reason of using machine learning in order to enhance that discrimination. And going deeper for our specific machine learning model, we used data from 6 different hospitals here in Brazil. You can see the map, Brazilian map. From January 2016 until October 2019 patients with 121,000 repeatable medical encounters, making more than 7.5 million data points. There was the workflow and the time frame established for these algorithms. So we decided to ignore 12 hours before the outcome of the patient, and the data set for training the model was at an average time of 24 hours preceding this 12 hours of the patient's charge. The feature selected here for prediction was vital signs, temperature, oxygen saturation, respiratory rate, blood glucose level, blood pressure, and also biological sex, age, ward, and length of hospital stay. And the target variable is the patient outcome, whether it's death or alive. Our results show that every model of machine learning outperforms the gold standard news. And what's really interesting that the machine learning model here outperforms in every hospital, in all 6 hospitals in a constant and robust way. One point very, very important, it's how to deliver this information. And so our predictions show to the healthcare professional through a wall dashboard. We also have desktop and application. We currently, as Matthias told, we are in 40 hospitals and some preliminary results showing reduction in the length of hospital stay, mortality, and cost. I'm just here, I'll point one example. We received a HIMSS Elsevier Digital Healthcare Award in Brazil and Latin America with the Hospital Marcio Cunha, with reduction in length of hospital stay, transfer to the ICU, intensive care unit, mortality that going results in a saving of more than $1 million over 1 year of implementation. Now, I'd like to share a little bit of our we have learned in this past 5 years implementing artificial intelligence here in Brazil. And we'd like to, in a didactic way, pedagogic way, just to separate in 5 dimensions, because I think it makes more sense to try to analyze it, but all are related. So the 5 would be the artificial intelligence itself, but in artificial intelligence, it's embedded, it's inserted in a technology, which is, by the way, inserted in an inner setting, for instance, the ward or a clinic. And you have outer settings and the health systems. All of these 5 dimensions have huge impact on implementation, success, and success of the pilots. First, the artificial intelligence itself is specific. We know the machine learning models needs a large amount of data to develop and validate. Since we are in developing countries, there's a lack of large clinical data sets for training artificial intelligence models. And this is especially true for supervised model when you have to put a label on the target. The data set needs labels that requires that the healthcare profession label the data set, and therefore it's more difficult to get, more costly and time consuming. There's more effort. And then when we have data, even when we have data, we have electronic medical records. They are proprietary, which means that each healthcare unit, either public or private here in Brazil, has their own solution, but built with different technologies and information models, with its own architecture and sets of business rule, as well as diversified clinical terminologies. So misuse of electronic medical records, it's very, very, very common. What happens, we usually integrate the hospital. We are here talking about our experience. And so we have to have additional layer of governance and trying to help the hospitals and the health care institutions to use correctly their systems. So here just an example for one. It's in Portuguese, but it's an example how we analyze in here. For instance, weight and pain, you have a high rate of missing values. If we were going to train and develop it, machine learning algorithms that use these variables, we have a huge problem on that. So we connect to electronic health records, we connect to the hospital, but also help them to use the electronic health records in a proper way. And besides that, we also needed to create an additional layer of trying to analyze in an epidemiological view this data coming from the hospitals. So we're currently building a Brazilian cohort. We had already more than 2 million unique medical encounters, and these medical encounters have 6 major domains with demographic data, vital signs, machine learning alerts from our machine learning models, medications, outcomes in hospital transfer, and laboratory exams. There's a distribution in South and Southeast and Center in our own country. And then we can definitely analyze real world data and make some hypotheses. Here, I'm gonna go through this graph because it's very interesting. If you see here, we adjust the population for Charlson, which is a comorbidity index. So if the patient has more disease, chronic disease, hypertension, diabetes, he points higher. So this patient's Charlson higher than 4 has more chronic disease or more severe chronic disease. And also point here if the healthcare plan was an insurance that is a private here in Brazil or a public. So we could divide and separate both and use machine learning in order to machine learning algorithms for clinical deterioration in order to classify them. And what we saw that these patients with even adjusted with comorbidity, adjusted with acute deterioration, it's our machine learning model. We saw that the patients from the public setting had worse outcomes, even adjusting for chronic disease and even adjusting for acute clinical deterioration using our machine learning model. It's very interesting. So this Brazilian cohort, it's going to bring some interesting insights for our population. And also about data, we want to shape the data. So we want to make sure that the data is native that was born in a digital right way. So we use LoRa applications, for instance, for healthcare professional to make some questions to the healthcare professional in order to label if, for instance, is it sepsis or not. It was used, this alert was used or useful or not in order to label it and to make more accurate data. And also using patient report outcome in order to communicate and talk to the patients and aggregate data with robustness. The artificial model, in this point, artificial intelligence also, it's very important here, the performance analyzing performance and biases. As we told, we have problems with data sets. So looking at this in a timely way, in the journey of the machine learning model, it's very important also. And we believe they'll have to go through algorithmic auditing. We defend that. And we were the first company in artificial intelligence in Latin America that was passed in this algorithm auditing by Ethical Consulting, which is a Spanish company. It was making possible because of Inter-American Bank of Development. So we hear there's a 70 page showing about the performance and some risks of bias that we use to correct and to go even further and better with our machine learning models. So it's very important to us to defend here. It's mandatory, should be mandatory to go through algorithm auditing in a timely and routinely way. And also we have to monitor the model deterioration. We know that the performance of supervised models is highly dependent on the context which they are trained, and this is special, as I told, especially with supervised models. So here, if you see, we work with some triggers, analyzing metrics, monitoring in a routine way, and if it's reached the trigger, then we know they'll have more details, and you bring inside the house to analyze and try to validate these triggers and the model. We also know that this artificial intelligence is implemented inside the technology. And here again, interoperability is a major issue. and it's not enough to emphasize that we need the standardization of the way we digitize information, we classify our information. But I'd like to also to point here that to bring it, to build the technology, we need most on the top people. And we know here in the developing countries that it's a labor shortage and also an unfair competition with foreign companies. We know here in Brazil only, the shortage might reach more than 400,000 jobs by 2022. And of course, the impact of national currency devaluation, it's huge. You can see here the currency, the real, our currency here, Brazil, in the last 3 years, we lost 100% of the valuation. So our costs have doubled, and that could have a huge impact on the cost and final cost to the client. So it's very important that we could also tackle this dependence of the service, or even increase and try to create more labor for this specific field. And here is not just clouding, but also WhatsApp. We use WhatsApp to communicate with patients. So that's a huge impact on our costs. And this technology is inserted, how I told, in an inner setting. And this technology has to come alive and interact with healthcare professionals and patients. And this operational aspect could be called the inner settings. In LoRa Clinical Intelligence, we can definitely define that, and the usage inside the wards, and the LoRa Care for outpatients. That's the platform for care coordination can use within the clinics. We are very in health, especially in medical school. We are very prone to usually look at outcomes such as mortality or length of hospital stay, readmission, rate, costs. But the problem here is the link between taking a pill, for instance, a medication, and the outcome is much shorter. That's not necessarily true when you talk about technology. With technology integration, have to take into account all these dimensions. And there's a long way between the implementation and the outcome. In order to see that, I think the Geneva model is the best way that suits this way from structures to outcomes. And the middle there is the processes. The process is a major determinant of artificial intelligence model and solutions implementation success. And there's two major determinants on this process. The first one will be technology acceptance, and the second one, how we use them to improve, and how do you use them, the technology, the platform, to make it improvement cycles. I'd like to share here also a technology acceptance model, which is a framework for acceptance, technology acceptance. And that states that there's two determinants. The first is PU, is perceived usefulness, which is the degree to which a person believes that using a particular system would enhance their job performance. So you perceive usefulness. And perceived use of use, the degree to which a person believes that using a particular system would be free from effort. So it has to be useful, and it has to be easy to use. To assess that, we routinely ask questions, automated questions. For instance, I use LoRa Clinical Intelligence platform to identify patients under risk of clinical deterioration who had here a high rate of conformity, and also LoRa Clinical Intelligence alerts cause work overload, a low agreement with this question. So we try to understand that through routinely questionnaires to healthcare team. But when we went to physician, that was not so adherent. They were not perceiving usefulness as we would like to. And going deeper with personal interviews, we realized that this came from two major obstacles. The first one would be interpretability of the models, of the machine learning models. The second by the data, the way data was shown and the way data interact with that. So to tackle the first one, we bring some sharp value in order to interpret the impact of having this data and translate that to the healthcare professional, rating the 5 more important variables. But that was not enough. So we saw that we needed to make a communication, especially with the healthcare professional, especially with the physician, through a device that would interact better with him. So we learned that nurses have a great adherence to dashboards and desktop, but physician didn't go that way. So we just launched a super app that allows physician to have instant access to all important information, clinical decision support, not just for clinical deterioration, but also for guidelines, for instance, antimicrobial stewardship guidelines. A second point would be a communication hub where the physician talks to all the team, the healthcare professional also, but in a regulated and a trackable way, because here in Brazil, everybody uses WhatsApp for that. And also show here in the third point, the machine learning models insights. And going deeper in communication, we also realized and noticed that we had to inform more in our dashboards, because we just had the Manchester colors and 1 or 2 variables showing that. And using a double diamond design and exhaustive interviews with healthcare professionals, we arrived to this dashboard. Here you have the LoRa score. That's a very important concept that we just translated and transform it from a classifier to a risk score in order to hierarchize the patient. So here's the LoRa score. You can see here all the variations, but also the vital sign, important signs of this patient, lab exams of this patient, which are altered, for instance, a blood culture positive. And this is the most critical patient. As I told you, we rank this patient through using machine learning model at 9.2, then 9.26, 6, and 8, and so forth. But also we have to change. And based on change acceleration process of GE, for instance, we have to sustain that change. And we identified 2 major points here. The first one is onboarding. The first 3 months of implementation of technology, they are critical. So we have a 9 steps onboarding, assessing both technology and workflow in order to have a high adherence, sharing a need, sharing a vision, and mobilizing commitment. But also we need to create we need to offer a platform that provides and permits, that allows that the healthcare team create improved cycles and retaining PDSA, plan, do, study, and act. Here's an example of our platform. So we have also the platform for the operation. In here, you can see the number and the rate of the patients evaluated within the ideal time. So if this hospital wants to evaluate patients within 1 hour, patients with a machine learning model alerts, then we could easily use that in as a go to the people who are in the ward in the front line. this has a huge impact on gamification and process adherence. And another thing that's very interesting, when to compare once we implement in the onboarding, one step of the onboarding is to analyze the machine learning models and compare it to the gold standard to use to that hospital, to the specific hospital. And we sat here with in a dashboard, and we all have a huge and an interesting meeting with the chief medical officer, chief nursing officer, the medical staff, in order to define the cutoff, the threshold of the machine learning models. Because we know that some hospitals need more specificity and some hospitals needs more sensitivity. That's very interesting because we also can adjust it during the flight, during the time. And here is data from a hospital that has no electronic health record. So the vital sign was inserted in our platform directly. And as you see here, we have what happened here. The nurse team noticed overload alerts. So after 3 months of implementation, we analyzed data, and after several meetings, we decided to change the threshold. And here you see the difference between pre and post the change of the cutoff. And here showing that you have higher specificity with major or minor or no impact in sensitivity. And this inner setting is always connected to the outer setting. Here, for instance, the hospital. The first point would be the quality culture. If you don't have a quality culture, it's much more harder and much more difficult to implement a new technology. But also the budget shortage is very common in hospitals, and the model of payment like fee for service, because when you go and say, I want to diminish, I want to decrease the number of length of hospital stay, and the hospital wins, or with more time of patient hospitalized, there's a conflict and it's more difficult to implement it. But also the other points, that difficult implementation, that's fear of the use of devices, for instance, personal iPhones, personal Androids. And two structures problem that we face is lack of electronic health records, and also lack of instability of internet. And you go to the health system, which is very important for the determination. You must understand how health is organized in a country. And here you can see in Brazil, we have a unified health system that covers, that's the unique coverage for more than 150 million person, 75% of the population. That's from simple procedures to organ transplant, high complexity hospital, guaranteeing full universal and free access to healthcare service on entire community. We analyzed in this paper our preliminary results of a response support by artificial intelligence. And we show that it's possible to use technology to support better care. However, we notice also a large variability in the performance on the use of technology among the cities that they use, mainly due to variation of the commitment and financing of the municipalities, because here's this decentralized payment. So one point that's very important, we believe that nation plan for adopting digital healthcare is essential to transformation. As an example of integration of new workload or workflow, you have a successful integration of healthcare, primary care in the preceding years. So if you want to truly put it and adopt in a digital healthcare, we must have a national plan for that. And now I'm just finishing. I know that my time, I think I have 1 or more 2 minutes. But just to summarize, implementation integration of artificial intelligence has to take into account all of these dimensions and should not be a static process, but yet a dynamic one, leverage quality and making possible cycles of improvement by providing not only the artificial intelligence per se, but the complete infrastructure of learning health systems. And of course, all this loop has to have the patient and the healthcare professional inside, in the middle, not just in developing, but also analyzing and following. So we truly believe that for artificial intelligence tools be implemented in a successful way, they have to be inserted in a learning health system. And to finalize, I'd like to leave this message here. I'm really fond of Greek mythology. I just love Greek mythology, and when I heard the comparison with the artificial intelligence and the interaction, human and machine represented by a centaur, I really like and enjoy it, because centaur is a mythological creature that's half horse and half human. And this guy is usually the good guy. But there's another mythological creature who also half animal and half human, the Minotaur. And this guy is the bad guy. And what's the difference between them? Why centaur has a human head enhanced by the force of horse legs, Minotaur has a beast head and has to be in his prisoner of a maze. In resume, we need human thought. You have human led. Always the human has to be in the center of not just design, but also the patient, for the patient, but also the healthcare profession. And we need here a human representativity from developing countries in order to develop and deploy artificial intelligence suitable for our reality in developing countries. I think I would like once again to thank the opportunity here. Thank all the team. We are on 80 persons that just love what they do here in Brazil, trying to rethink and reshape health. And I'll be glad to answer any questions and exchange experience. Thank you very much.
Thank you, Hugo. That was fantastic. And I loved your Greek mythology reference at the end. Can you just tell us a little bit before I delve into the questions? Where is Laura now at? You mentioned you have 80 employees, and is the company standing on its own feet, or are you financed? Yeah, how are you financed at the moment?
Yeah, I think thank you. That's a very good question. We founded in 2016, and then we used to make as a bootstrapping, so different works for outside health in order to finance our project. And in 2019, we decided to go health specific and transform our products into software as a service. In 2021, in the beginning of this year, we received a seed funding of 2 point something, it depends on the valuation, but $2.5 million. And we were already on a break even, but now we are fomenting, we are investing lots of interoperability. So even larger and larger, looking at interoperability, not just in the technology way, but also in the epidemiological way. So we'd like to enhance that. We also had the opportunity to create a research team. So nowadays we have a research team focused on research and scientific publication. We are currently in 40 hospitals from southeast, just in the north, there's no hospitals in North, but we are looking at. We are currently in different cities and working as insurance plan operates providers and also in the public sector.
Okay, that's very amazing, and congratulations on receiving that seed round. Let me start by a question by Haru, who was wondering, and you mentioned that as well, that internet access is one of the issues impeding your projects. What's the minimum data rate required? Is it 10 Mbits, 100, or 1 gigabit even to have the system running?
Haru, thank you very much for the question. I don't know. I'm sorry, because I'm a chief medical officer, and we go back more in I don't know. I don't want to say something that maybe it's not true, but okay. if you we could definitely exchange, connect, and then I can go to interoperability integration. Then I can definitely give your answer. Sorry about that.
Sounds great. So let me turn to the Q&A. Please submit your questions here, and we still have 10 minutes, so go ahead. For Miron Odingo, yes, the session is recorded. You can rewatch it on YouTube or Twitter. And then Ariane Sasso had a question, and she was wondering, how did the training of your gradient boost machine work? Was it trained on data from one hospital and then evaluated and benchmarked based on data from other hospitals? Or did you sort of just put it all in one pot and then trained the models and went from there? Maybe you can tell a little more about how that worked.
Yeah, it was for 6 hospitals, and currently we are submitting a new paper with 14 hospitals, and with leaving one group out and 10-fold cross-validation.
Okay. And can I ask you, when you approach a new hospital and you deploy the model with the hospital IT folks, do you observe any issues? I mean, there may be a shift in the data shift, there may be different X-ray machines, there may be different patient populations. What are you doing to ensure that your models are working as they're supposed to? And did you have any issues in the past when deploying to new settings?
Yeah, that's also a great question about data set shift, especially here with pandemic times. So we have automated model monitoring, as I showed you. We have a trigger points, and every time the trigger from F1 AUC, they are reached. So we analyze them internally and trying to decide what happened. I just showed one example, but that example was F1 score that was better. So actually it was for best, not for worst. But we do look at that, and it's one thing that's very important in the onboarding is trying to analyze what's the workflow of current workflow, because we have here from very high specialized and high quality hospitals with Joint Commission that has all the workflow working, but also have hospitals without a rapid response team or without physician. So trying to set those two different settings and contexts, that's very difficult and hard. But it's very important to see what's the current workflow and trying to adjust and to put it in the meeting. One of the main goals of Brazilian cohort that I just showed is trying to learn from that, also to learn how the difference and the data that I show also we saw that patients from healthcare public, they go worse than private, even adjusted to acute and chronic conditions. So that we should look at that and ask ourselves, why is that? Why is the patient who has the same acute and chronic condition, because he's in a setting, hospital, public setting or private, has different outcomes? And trying to learn from that and try to leverage quality.
And Hugo, so all of the data you showed were based on retrospective analyses. Are you having any trials ongoing where you randomize patients into care or monitoring with LoRa and others receiving sort of standard of care to see if outcome is changed between the two groups?
Yeah, we're currently going for writing a protocol of a clinical trial, but because we understood that we had to change some kind of communication, especially in the dashboard that I just showed, especially with the application, we hold that because we want to see adherence to processes in real life. I think, like I told, it's more important, it's very important to have well-designed processes and adherence to processes. If you go to a clinical trial, maybe you're gonna have a high number of, it's high complex, and we will not learn from it. It's better to understand step by step in a very lean startup way through iterations.
Now I want to focus a little bit on how you included the different groups that are necessarily involved, like patients. But I first want to ask about, for instance, nurses. Did you observe many false positive alarms where nurses are being alarmed, but then it was only the patient removing his pulse oximetry sensor, and nurses just go to the doctors and are really bothered by all these alerts from LoRa?
Yeah, that's the reason why we think that's a continuous way. You have to go, not just deploy a high, have to see because each ward is different, because each context is very difficult. So it's important, the concept of learning community inside the hospitals, in order to them to learn from that and try to make progressions. For instance, we can every 3 months analyze with them and try to reset the threshold. If the nurse team thinks there's too many false alerts, we could definitely go to a higher cutoff threshold and follow to see if there's false negative, or how sensitivity and how specificity. So I think the major challenge here is not, there's no a magic answer. You have to go day by day. It's in the details. Okay. I just heard the devil is in the details. I think it's because I have to go continuously every day, like raising a child. I have to create the connections. I have to see it happen, just making the progressions day by day, not just one magic solution. And the idea per se of a magic solution, it's not good for healthcare.
Okay. It just reminded me of a colleague who's continuously comparing training his models to raising a child. And in some ways it may be true, but not necessarily in most.
Yeah.
I want to turn to a question another one by Ariane Sasso and Michael Strange, who are wondering if patients know, so I'll just read it out. What materials are given to patients so they understand how their data is being used? And also, how are they involved in the design of the apps? For example, is there a user-centered design or design thinking involved?
Yeah, thank you very much. We have basically two solutions. One is LoRa Care for outpatients and LoRa Clinical Intelligence for inpatients. In the hospitalized patients, both of them in the onboarding, we have a lot of material for marketing, because it's very important to the physicians, to the nurses, and also the patients know they are being cared, and they have the quality improvement in their settings. For outside patients, it's even more important because engagement and adherence, it's more dependent of marketing. We analyzed, and in this preliminary result that we just published, we saw that marketing was an essential factor. So if the city wants to put advertisings, the city municipality decide to put on the website and making ads about it, the number of cases of a number of utilization and use is much higher. So it's a huge critical point, especially for outpatient.
Okay. Christina is asking, how is LoRa different from its competitors? Seeing that there's so many people working in the space, what does LoRa make different?
It's a very good question also. I think one thing that's very important that I just finished, we are from developing countries, and we know the pains and difficulties from developing countries. One thing that I think we should look at that very carefully, but also because we have the complete journey of the patient. We design commencing, we started with a hospital setting, but then we just break the walls for the hospital, and now we are on the complete journey of the patient, assessing classification and also patient report outcomes for outside and care coordination, and assessing important information from inside the hospitals. And throughout the years, we have there's 2 million in the unique medical encounters in our database, but there's more in their warehouse, but there's more than 10 million in our data lake. So we have a lot of information coming up from here, from the integration of the patient journey.
Okay. Carolyn's son is wondering about how you mentioned that physicians and nurses get their own version of the LoRa app, because they have different demands and expectations of it. And so Carolyn is wondering if there's any plan or benefit of having the two groups interact and share how they use LoRa.
Yeah, it's very, very good. And Caroline, it's our, we know her. Thank you very much for
Nice.
being here.
Thanks for showing up, Carolyn.
It's our academic partner, so she's a very, there's a beautiful track in analyzing technological implementation, and we are actually make some partnerships in order to evaluate both physician and nurse impact. So one thing is yeah, it's different mainly because the platform is the same one. What is behind the back office is the same one, but we noticed that the interface has higher adherence with desktop and dashboard for nurses. It's not different desktop and dashboard, it's the same one, but they dialogue with desktop and dashboard in an easy way. And the physician, it's much difficult to assess through desktop and dashboard. That's the reason why we have the LoRa application. And the LoRa application is very similar from the nurse and the physician. There's a question of permissioning. It's different logins, but it's very similar. The way in the interface is very similar from one and another.
Okay, so I want to close with the question: where do you see LoRa in 10 years from now? And maybe you can touch upon whether you're already in touch with regulators, whether there's an issue with post-market updates and so forth.
That's great. It's very 10 years from now. If you ask me 10 years behind, what would be of myself in 10 years, it would be completely different. So Laura, but for Laura, I think it's this journey of the patient. So we want to establish a real robust data privacy, data security, scientific papers in order to validate in an iterative way this revolution, because we are changing the way we care. And we have to, I like very much the way they start up, lean startup with interactions. So we are going to the uncertainty. We have to go step by step. So we'd like to have a patient journey of the patient, a patient journey, leveraging better care and making it possible to every healthcare provider to provide the best care and every person to be cared by the best care and make these connections. We definitely want to go foreign, outside. Actually, I'm going to Portugal in 2 hours.
Wow.
Yeah. And we are, also talking with Inter-American Bank of Development to start in Latin America, other countries, and trying to make it possible to connect the best treatment to the best care to the patient and provide healthcare professions be possible to provide the best care. We definitely want to impact 1 billion people in 10 years. That would be a huge goal. Yeah.
All right. Thanks, Hugo, so much for this excellent talk. It was really inspiring, the journey, and from when you started just a few years ago to where you are now. It's really impressive. Thank you so much.
Thank you, Matthias, for inviting us here. Really a great opportunity, and we are very open to academic partnerships. We're very open to scientific publication and also to partnerships at all. Is it just? I'm sorry, I know the time, but we also have agreement, cooperation, technical agreement with Ministry of Health in order to put in our hospitals here for the public sector.
Okay, that's great. We'd like to launch a quick poll that'll appear on your screen. Please let us know if you'd recommend the AI and health webinars to your colleagues. And also next time when you hear about the next webinar, the next one is going to take place in 2 weeks, please share it widely. I think this whole webinar series depends on many people sharing it and recommending it. And that'll also help us attract inspirational speakers such as Hugo for the next sessions. And with that, again, thank you, Hugo. Thank you, AI for Good team in Geneva, for making this all possible. And I hope to see you all next time. Have a good rest of the day, or have a good night wherever you are. Bye-bye.
Thank you very much. Bye-bye.
Selector, rewind selector, rewind selector, rewind selector, rewind selector, rewind selector. Selector, rewind selector, rewind selector, rewind selector.